So thanks for introducing us and inviting us. So I'm going to start. I'm Andrew Webster. I work at Moorfields Eye Hospital and UCL Institute of Ophthalmology. And Nick Nettleton is going to join me too. He's involved in this project with me, and we'll give an update on where we are with the project once I've given the background to it. So I work with rare disorders affecting the retina, particularly genetic disorders, including macular dystrophy in young people, and that's a large part of my work. And one thing that I've noticed is that it is difficult to get enough clinical data about these conditions from people and bring it together to learn from it. That's the challenge we have in rare disorders. I work with colleagues that work with common diseases like glaucoma or age-related macular disease, diabetic retinopathy, and because those are common, they have a lot of data to use in any one hospital. So in Moorfields Hospital, my colleagues are able to put together many histories and images of people with age-related macular disease and learn from them towards hopefully treating them better, so that we can treat people in a more personalised way by learning about the condition and the way it progresses. We'd love to be able to do that for rare disorders such as macular dystrophies, but we can't because we're limited by the numbers that we see in any one hospital. And because I'm interested in research and I've got a lot of collaborators around the world, we have tried quite hard to link together data between us. And that's a challenge because first of all, we need an ethical framework to do that, and that's bureaucratic and it takes a long time. And that's important because we have to protect the data and we're working on behalf of patients. So we have to make sure we're doing so ethically with their data. And secondly, there need to be agreements between institutions to share clinical data, which often involves a lot of bureaucracy and also lawyers, which always slows things down. And so I've seen a lot of these attempts to share data fail. And one way that might make that easier would be, instead of working on behalf of people behind the scenes, give the patients themselves the job of joining up. And so we thought that the natural thing to do then would be for patients to look after their own clinical data if they wanted to have it copied to a resource outside the hospital. And that way we could join up people from different institutions and different countries. And that's important because each of the disorders that I deal with is rare. The most common one, actually, Stargardt disease, which people in the Macular Society are affected by. That's the most common single gene disorder in ophthalmology. But that only affects about 1 in 8,000 to 10,000 people. So there'd only be about 60,000 people in the whole country with that condition, which sounds a lot, but you know, we have to join them up from different institutions. If we were to go global and join up with the States and with Europe and with China and India, then we'd gain a lot more insight into that condition and the different subtypes of the condition. And that would benefit everyone, benefit our development of treatments, help drug companies do trials more rapidly than they are at the moment. So that was the one main motivation for starting a site that allows patients to have copies of their data that they control, and if they want, to link up with others for research purposes. And the other reason was just sitting in clinic, seeing people that had been referred from other places. And at Moorfields, that happens a lot. We see a patient that may have been referred from a hospital in which they've had plenty of tests on their eye, which include images and electrophysiology and visual acuities that we don't have at our disposal. I can't see it as a doctor that is looking after this patient. It's very hard to get. And unless the patient has letters that they bring with them with that information on, then I can't know of it. And it's surprisingly hard. It surprises many people who I see how hard it is for me as a clinician in one hospital to get information about them from another hospital. And I don't think that problem is going to be solved anytime soon. So having a site in which the patient looks after their data, copies of their data, makes sense, because if that were there, they could collect data together, not just from hospitals, but from optometrists who gain very useful data these days on these conditions through the images they take with their cameras. They could then control it and they could share it with a doctor who is then looking after them. And so we could save a lot of time and a lot of unnecessary trips to hospitals. And recently, of course, with COVID, we're trying when we can to see people by means of this, by means of Zoom or another application that allows us to join up. So we're trying to reduce the footfall in hospitals, and whenever we can, talk to people over an application like this. But one thing we can't do is take photographs of them. And so now there's an interest in having the photographs taken locally, perhaps at a local optometrist that is close to them, and sharing that with the doctor that looks after their condition more remotely, say in somewhere like London or Manchester or one of the big centres. So those motivations came together, and it made me realise that we needed to develop a site in which patients could own their own data for those two reasons, to help with research and to help with clinical management. And so one of the things that happened during the course of thinking of this was GDPR, General Data Protection Regulation, which scares everyone in hospital. We have a whole information governance department, and we have to, as members of the hospital, we have to take a mandatory training every year about information governance, how to look after sensitive data. But one thing it does is empower people. So people can now make an access request to places anywhere that has data on them, and hospitals have a lot of data on them, and they can request to receive their data in a form that is useful to them. And so that empowers people to get their data from places like optometrists and like hospitals, and it would make it easier to develop a site that holds copies of data for people. So we came up with that idea, or at least I was thinking of that idea. Now, being an ophthalmologist and not a technical person, not a software developer, I couldn't do that. But then by accident, I met someone called Nick Nettleton, who was a techie, an insightful and articulate one for someone from that speciality. And we realized we both wanted to do a similar thing. And so we applied for some money to get this started, and we were lucky enough to get funded by HDR UK, and since we've had some more funding from Innovate, and we got the project started. So that's how this MyEyeSite came about. That all happened about over a year ago now, and so we've been, well, we've been at it for now at least 18 months developing this site. So that's the background, and we can go into that in more detail with questions in a moment. I think this is a good time to hand over to Nick Nettleton, who's with us and is going to tell us where the project has got to from now. So, Nick, I'll hand over to you, if I may.
Thank you very much. Can you hear me okay?
I think that's fine, Nick.
Yep, you can hear. Great. Thank you, everybody. Thank you, Andrew. So yeah, as Andrew said, I'm a techie. I've been building applications, web applications, for 25 odd years of my career, and mucking around with robots and things ever since I was a child. So it's my bread and butter. And my passion has always been for web applications that are really easy to use, that empower people, and that help people collaborate and do things they can't otherwise do. And we've built big applications for business globally that transact hundreds of millions, and small applications as well. And a while ago, my eldest boy, 4.5 years ago, when he was born, and we went to hospital, and that was a relatively routine birth. But I noticed it was just complete chaos, and the poor nurses, the midwives, the doctors were working incredibly hard and doing a great job, but really struggling against the systems that they had. And they didn't have their 4.5 years ago, even what I would think of as relatively basic technology systems. And this was in Whittington Hospital in North London. My second was born in UCH, which was a bit better. But in both cases, it kind of really inspired in me this energy for the type of things we've done in other fields. Why can't we do this in health? Why is health so far behind? Or certainly in the UK, I don't have experience of health services in any other country, but certainly in the UK, so far behind the rest of industry in terms of technology and empowering people and enabling people to collaborate. And so when I met Andrew and we got talking about ideas, and I was really interested in this idea of patients being able to pull together their data and link that with their genetic data and make use of that, and in so doing aid science. And we talked about it. I almost fell off my chair when I realized the extent to which the trouble that Andrew had in just getting hold of people's data. And it never ceases to amaze me when I talk to patients through sessions like this or the patient days we've had through MyEyeSite, the trouble that people face just getting hold of everyday information and working with it. So that's really become a sort of a driver for the project. And so once we started talking and had this, Andrew brought this, well, when we first started talking, we wanted to enable people to bring their data together into an application and share it with science. We went and spoke to some people in various universities and hospitals, and they said, you can't possibly do that. It's not their data. They don't own the copyright. And so I went back to Andrew and said, I think we're going to have problems here. And things went quiet for a bit until I think Andrew said, well, but what about GDPR? Which was absolutely right. That law enables us all as data subjects to demand that organizations hand over our data, and they have to unless they've got a very good reason not to. No, they have to do it within 28 days. And the ICO's got real teeth. It can fine them a lot of money if they don't do it. So people are scared of GDPR, as Andrew said. So we thought this is really exciting. Actually, we can break through all this bureaucracy and these layers of people who want to stop information getting into the hands of patients, and create a process that enables patients to bring that data together. And then through doing that, we can enable, for the first time, people who've created a lifetime of data in lots of different places to start to bring it all together and link it and create some order to it that doesn't exist now. And make that data available for their doctors before an appointment, or for scientists for research studies that are relevant and interesting. Something that to me seems that it should have been done years ago and should be quite easy, but we've been working quite hard at it and we found it's not easy. We were making really good progress, and that's what's exciting to be able to say. So when we applied for the HDR UK funding, this was in late 2018. We pulled together our application really quickly, and to some extent, I think we felt Loft is the name of my business, and we felt a bit like the outsiders. We're not a big company, and we're looking to break into this world of digital health, but we have a really good track record in building systems with lots of data, and we have a really good track record in having a very good focus on what users really want in applications. So we decided to put that at the front, because what we noticed was that in health services, users haven't really been put first. Everything's been about the system and the technology. Nothing's really been about the users. So we decided to take that angle, and we structured our whole funding application for the initial, it was called a feasibility study and prototype, around having a very patient-centric model for how we're going to conceive what this application is. So if you think, so Andrew and I, we had a sense of what the problem was. We had an insight that here's a solution. We can use GDPR to get the data to hands of the right people, and we can, through that process, enable them to then share that with doctors and clinicians. But that's not a solution, that's an idea. And in technology, we need solutions that work for real people. So we built this program of sort of patient days and user research, which we implemented through 2019. And through that, we met lots and lots of patients, lots and lots of people with rare eye disease, lots of scientists, lots of doctors. And we learned a phenomenal amount about the challenges that people face on a day-to-day basis. And we're still learning. And by the way, after this, please, ask those questions, because the more we learn, the more we can make sure our work aligns with what you need. And one of the really interesting things that we learned, which sort of, again, kind of superpowered our energy to create a great product here, was that it wasn't just Andrew and his colleagues, the clinicians who desperately need access to their patients' detailed records. And it's not just scientists, researchers who are trying to discover the causes of disease who need access to it. Actually, for a lot of patients, they really need this themselves. We met people who were walking around with great big folders full of every letter. So these are the really organized people, often super mums with very unwell young children, with folders with every piece of paper from every appointment that they've ever been to anywhere. And they take this, they lug this with them to every specialist they go and see. And they try and find other people with similar conditions and form networks and support groups. And I started to realize actually that this data is an asset, not just to healthcare and to science, but it's an asset to the individual. We all need our data and we have a right to our data. And actually, when we bring our medical data together and put some order to it, it becomes an asset that we can use ourselves to further our own life outcomes and to improve our sense of agency in our lives. And that's an important thing for us all to have. So that was a really, really sort of exciting insight. And then as we built on that and we developed our designs for the application, we worked very collaboratively with a number of patients with rare eye disease who've been involved since the start of the project. And we had some involvement from the RNIB to help us with accessibility. And we prepared a prototype, which we took to a second patient day, which we presented to 50 or 100 odd people who were there for their brutal feedback, which was brilliant. And we learned all sorts of really useful things there as well about, for instance, the different types of needs people have for accessibility, the concerns people have about sharing data, how willing and excited people are about the opportunity to share data, lots of things like that. And that was really valuable. I think for me, one of the key insights in that, we really wanted to test with the audience there, what's the long-term commercial strategy for MyEyeSite? How do we make it a sustainable, having built the prototype, our minds was turning to the fact that we've got a really good idea people here and people really like it, but it can't be funded on grant money alone, we don't think. What's the future? And we looked at a few options. One option was, should we ask patients to pay for an app, 10 quid to get it from the App Store or something? And we really didn't like the sound of that, because that would exclude a lot of people, I think, either financially or simply because, only 1 in 100 people would actually think it's worth paying that much, and therefore we wouldn't get the data that we wanted. Should we look to the health service for this? There's opportunity there, but also we've been advised that if you're looking for the health service to financially support your product, you might run out of money before they get around to signing the contract, even if they think it's a very good idea. So that's an area of concern. And so really we're looking to research. It seems to be where a lot of the value is created. So we wanted to sound out the audience and understand how do you feel and how will you feel about using MyEyeSite as a place to bring together your data, but also being able to pick out research studies within MyEyeSite and say, yes, I'd like to be involved in that. And yes, I want my data to be involved in that. Or in fact, would you like your data to be available for every research study that is relevant and interesting? And we had really good feedback from that. And it seems that providing MyEyeSite is taking an approach with good governance and good ethics and a transparent model, that the audience is on board and very happy and indeed really wants as much data as possible to be made available to accelerate research. So that's something that's been really, really useful to learn, and we'd value your input into this as well later. So with that sort of energy and steam behind us, we powered ahead and developed the first functional prototype. So it's a proper working, or it was then, this is earlier this year, proper working web application, which we could test, do an alpha test with a number of patients and find out if it actually works when they use it on their device. And that was a great success. People were very happy with that. We had a lot of feedback, recommendations for improvement. And there our initial funding, or the scope of our initial project engagement with HDR UK ended. And we were very happy with what we achieved, but wondering what to do next. So I think we all sort of, in February, sat down and scratched our chins and thought about how we take MyEyeSite forwards the next step and where we find the next project from. And then of course there was a pandemic and everything turned upside down, and I said to Andrew, what are we going to do? And he said, well, do you know what? We've got a problem. We've got a really big problem. We're not allowed to go into the hospital. We don't want patients coming into the hospital. I have to do consultations with them through Zoom, or actually a different application called, I think, Attend Anywhere. And now I haven't got any way for them to really share their information. They used to bring it in on a bit of paper or show me on their phone. Well, now how am I going to do that? I haven't got a way to do that. and say there's a problem. So and then if you remember at this time in sort of April, the government was panicking about how they're going to keep things moving in lockdown, and they announced a tranche of funding for projects that are relevant to social distancing or COVID, to get quick turnaround funding. So we thought, well, let's put in an application for that, to see if we can use that to help us bring MyEyeSite from its current position as a prototype to an application that is in beta. And the main goal that we wanted to achieve is that we would be able to put in place a number of improvements the patients had asked for, and the clinicians had asked for, and the layers of security and compliance and legal infrastructure needed to have real medical data, so real patient information in there. So we've been working on that, and that's now come to fruition. So the application's now live in beta, and we're asking patients to go to the website at myeyesight.health and register your interest if you'd like to be involved in the beta. And what we're doing is we're gradually we're providing quite a handheld service initially, because we really want to talk to everybody using the application and understand how it works at this point while it's small, before we scale it up to be very large. So we're looking for people to come and join that gradually. So that's where we are now. And then looking ahead, our next project is how to transition MyEyeSite from its current position as a beta into a fully live production application, which we can scale up to everybody with a rare eye disease. Is that a good précis, Andrew? Do you have anything to add?
Nick, thank you. That's great. If there's 5 minutes left for our half hour, I might just say a bit about, we've heard the word data a lot. And what that means in rare eye disease and macular dystrophy. I might just a few words about what sort of data is useful in the clinical disorder and in learning about it. So clearly in the eye, we're lucky in that we can access the retina very easily through photography and take some very accurate images now of the back of the eye. So ordinary white light photographs or color photographs are useful, but even more useful are the photographs we have through an OCT machine. That's looking at the layers of the retina and finding out exactly what's going wrong at the cellular level, merely with a photograph. We do that in our clinics, and we've been doing that for 2 decades now. Optometrists now do that very well too. So that sort of data is prevalent, and it's possible to get that from a relatively routine optometry exam. So all of that data is useful, and people accumulate a lot of it with a rare disorder such as macular dystrophy. Over decades, they have this data, and that we can learn from that. We can learn about the natural history of the disorder very well, if only we could get it together in one place. But not just the high-tech data like that, the low-tech data is important to us too. So a person's biography. And so very often in medicine, we take a history from a patient and ask them to describe their problem in their own terms. And that's very useful to us, particularly in ophthalmology, to understand what's going on. And so MyEyeSite will give the opportunity for people, if they want to record their story when they first noticed a problem with their vision, what that problem was, perhaps some anecdotes that led them to realize that their vision wasn't normal. And that can be helpful to us too. When the diagnosis was made, the age at which these things happen is key to understanding the progression and the type of disorder that's occurring. So that's useful data to have. And then also data such as reading a Snellen chart, the visual acuity, a basic psychophysical test in which the person reads to the lowest letter they can see and recognize. Now in macular disease, that's fundamental. And so to have a timeline of a person's visual acuity would be helpful. And that sort of information is available from every optometrist visit that a person makes and every hospital visit a person makes too. And we're hoping also that that sort of information can be gathered at home. There are some very promising applications on a phone that will allow people to record their own visual acuity from time to time. And that's information that could be supplied to the doctor when they have a next appointment, if only there's somewhere to put it, such as MyEyeSite. So that's the sort of data we're looking for, and we think if we can get that, we'll be able to improve clinical management. We'll be able to reduce the footfall in hospitals and the journey people have to make to hospitals, because they'll need to do it less frequently, and it will really motor research into rare disorders. So Felicity, I think we've probably said what we need to say now, but if there are any questions, then that would be helpful. We can answer those.
Yeah, brilliant. So I forgot to say at the beginning, but if anyone's got any questions, then please do put them in the message box. We've had one here, and it's a question that, is this approach going to be developed for, or is it being developed in other disease areas?
Over to you, Andrew.
So what part of the feasibility project was to find out what else was out there in this sort of area. So applications in which patients could keep track of their own data. And there are some very good applications. Patient Knows Best is probably the most well-known application. And so, yes, there are applications for patients to keep track of their own disorders. We haven't found many that give patients the complete control of their data. And so Patient Knows Best works with hospitals and allows patients to access their data within a hospital, and they can add to it, I think, as well, and control it to a degree, but they still have to work within the hospital system. And that has limitations, because they can't then join up with other patients that they don't have a relationship with. So our model is quite unique, giving the patient to the data, and then it doesn't matter what institution they get the data from. We don't have to seek an agreement with the eye hospital in Glasgow or in Paris. You know, we surmount those limitations. So that model, I don't think we've seen unless you can remember an instance, Nick. We did look quite hard. So it seems a fairly new idea, at least that model of having patients really looking after their own data out with institutions. And it would be relevant to other disorders, particularly relevant to other rare diseases. The reason it's relevant to rare diseases is that rare diseases are usually lifelong. They usually involve a lot of data on behalf of each particular person. And it's particularly hard to get it together in one place. So joining up people with diabetes and learning about diabetes isn't so hard, because a lot of people, it affects 1 to 2% of the population. And so any one hospital or group of hospitals could command a lot of data and learn from it. And that's already happening with age-related macular disease. And we're learning an awful lot about age-related macular disease, even having algorithms that can prioritize people that need treatment quickly. That's a really useful thing. And my colleague Piers Keane has been involved in that. And so when we get enough data together, it can be very useful. But we haven't seen many instances for rare disorders, and we haven't seen the model in which people look after their own data. So it is fairly unique. But importantly, just to end, this is a paradigm for other conditions. And so if it works for rare eye disease, it should work for neurological disease, heart disease, hormone diseases, kidney disease, etc.
Sure, so this is leading the way, really. The eye disease, the knowledge you're getting from eye disease will lead the way for other conditions. Great, okay, well that's been brilliant. Thank you so much to both of you. We have got another question here related not to this project, but related to the 100,000 genome project. He has an undetected fault causing macular dystrophy in his family. Is there any news on how the eye-related work stemming from the project is progressing?
So the 100,000 genome projects, the Genomic England project, we're all involved in. So doctors involved in rare disease are very much embedded in that project, because it's a unique project, and it was very early on in the technology. So England got on board with that quickly, which is a great thing. So I'm involved in that with eye disease, and there have been already a lot of good work that's come from that, and the analysis continues. So an example of what can happen, a new cause of macular dystrophy, for instance, we published on this for Moorfields with collaborators, has been found from that project, this is a gene called CDHR1 that normally causes quite a severe retinal dystrophy, more like retinitis pigmentosa. It actually affects the whole of the retina. It's quite a severe disorder. It was a surprise for us to find that people with relatively late onset macular problems, that wasn't age-related macular disease, it didn't look anything like that. It was a surprise to find these people in the Genomics England study and in other similar studies pop up with mutations in this same gene, because it didn't fit with what we knew about that gene. This gene had been around for 10 years, CDHR1, and we thought we knew what it did. And so we were surprised when actually different changes in the gene give rise to macular dystrophy. The peripheral retina remains intact, but people do have problems with central vision. And that's happening increasingly. And so what the Genomics England study does is sequence every gene. It's an unbiased appraisal of our genome. So we're not just looking for known genes in a person that's got macular dystrophy, we're looking at everything. We're open to everything. And so we find surprises like that, in which genes we thought we understood actually have more subtle effects and can cause different disorders. And there are an increasing number of situations like that. There are genes that can cause severe neurological problems in children. For instance, Batten's disease is one such condition. And we're finding that certain spelling mistakes give rise to central visual problems. And there'll be some people in the Macular Disease Society actually with those changes. Their general health will be fine because these changes only affect the central retina. So that's one example of how the Genomics England project, because it looks at the whole of the genome, all 3,000 million letters of it, does for us. It shows us these surprising results, these subtle changes of genes that we wouldn't have otherwise have predicted. And it can also find changes that we don't find with standard genetic testing so far. It looks at things called introns, so genes, for those who know, many won't, genes composed of two types of DNA, one called exons, which are brought together to make a protein, and the bits in between those introns, which exist in our DNA code, called introns, intervening sequences, and they're spliced out. They don't seem to do anything. And they're longer. There are many thousands of base pairs rather than the few hundred for each exon. And so we need whole genome sequencing of the sort that's done in Genomics England to look at those introns. And we're finding that many people actually, particularly with macular disease, and particularly with the ABCA4 gene, many people have changes in those introns that explain their disorder, which otherwise would have been missed. And that's been one other triumph so far of this study. So a lot is happening. Patients may not know about it, and we are trying to develop some seminars for people that have been taken part in the eye part of the Genomics England study. There are many thousands of people nationally that have entered as families with eye disease. So we're hoping next year to start a number of seminars in which people like me and my colleagues who do the research can feed back to people and tell them what's going on and answer some questions. So hopefully people will hear about that through the charities, and the Macular Society are working with us, because many of the patients, many of the people, members are actually members of contributed to the study. So I hope that answers the question.
Great, thanks. And yeah, any updates on that, and we'll keep everyone informed on how they can get involved and be part of those. I don't think we've got any more questions, so thank you very much to both of you for joining us this evening. I hope everyone has enjoyed that. We have another virtual clinic for the working age audiences on the last Thursday of November. And in the meantime, thank you, Nick and Andrew.
That's a pleasure. Thanks for having us.
All right, thanks very much, everyone.